hosting this conference on IPT for eating disorders, which is sponsored through Project CORE, creating opportunities for Rhode Island eating disorder professionals. Andrew's going to introduce our esteemed speaker for today.
So we are happy to welcome Dr. Robyn Pashby, who's a clinical health psychologist specializing in treating people who are wanting to make behavioral changes. She's experienced in the use of interpersonal psychotherapy and cognitive behavioral therapy for eating and weight disorders. Her specialization is in the psychological treatment of obesity and binge eating disorder and working with pre- and post-bariatric surgery patients. She currently is the owner and director of DC Health Psychology, which is a group-based practice with offices in Washington, D.C. and Maryland, and RBA Health Psychology, a division of the DC Health Psychology program that's located in Richmond, Virginia. She's also created and leads an online weight management coaching program called Health Gains, and is currently the Vice President of Professional Affairs for the DC Psychological Association. You told me I didn't have to read all this. So. We identified Dr. Pashby through a common colleague that we have, Marian Tanofsky-Kraft, who's done a lot of work testing interpersonal psychotherapy for binge and loss of control eating in adolescents with overweight and obesity. And Dr. Pashby trained with her in the DC area. So we are so happy to have her here today to share her expertise. And I just kind of want to mention, this is such a great opportunity because there are very few providers that are trained in doing interpersonal psychotherapy. And I've been doing this work for like 15 years, and I have never come across a training in IPT for eating disorders. So you guys are all very fortunate to be here, and I am so glad that we have this opportunity as well. So thank you for coming.
Thank you. So before we get going, in your packet you will have the description, objectives, and then on the back you'll see our agenda for day one. So we will be taking several breaks and a lunch. Quickly, does anyone need gluten-free for lunch? Because we do need to know that ahead of time. Okay, so one person. Oh, great. So we'll make sure that we have that. And yeah, and there is one gluten-free. And if you need anything as throughout the day, myself and Andrew will be your contact person. Again, we're thrilled to have Robyn here, and I feel like we are really on the cutting edge to be able to learn this and integrate it into the Rhode Island community. So thank you.
Well, good morning. So I'm acutely aware that this is a long training, and so please feel free at any point to stand up, go to the back of the room, and just stay standing for a while. I'm always the strange one in the room that does that at long conferences, so I really want you guys to feel comfortable. And I really hope that this is a discussion. So I have a lot of information and a lot of experience, but so do you. And so I really want this to be a give and take where you feel comfortable contributing, asking questions, not just at formal question points, but just in a conversation. Okay? All right. So here we go. I will ask for patience because I just got a tutorial about 15 minutes ago on how to toggle back and forth between all these different screens. So I'll get better at it as we go. Okay, so overview, we are going to talk about IPT, of course, and we're going to talk about the background and theory of IPT in general. So we're going to start with what is interpersonal psychotherapy, and then we're going to move into interpersonal psychotherapy for eating disorders, and then we're going to move sort of back out into general IPT, and then back into IPT for eating disorders, and so forth. The reason for that is that, number one, I'm going to move around a lot, I'm sorry. Because number one, as we've heard, there isn't actually a lot of training resources for IPT for eating disorders, so I'm going to be using case examples for eating disorders, but also for other things, depression, postpartum depression, those types of experiences, because we have to be able to look at other training opportunities. So then we're going to go, as I said, specifically around IPT for eating disorders, and I'm going to talk about the theory and phases and techniques, as well as review the tools that we use in IPT specifically. Then we're going to wrap up day 2 with treatment non-responders. How do you problem solve around that? How do you know who's a good candidate for IPT for eating disorders? what are alternatives. So we're going to kind of zoom in and zoom out a lot. Then we're also going to cover adaptations of IPT for eating disorders, looking at how you might use this in a group setting, how you might use it for adolescents. Most of the talk I'm going to do is sort of toggling between adolescents and adults, but I'll talk about specific adaptations that might be used for adolescents. You guys have a copy of this agenda. We're going to go closely by it, sort of. We're starting a little bit late, so we'll do our best. If you need a break, take it. The reason I'm going to go through these objectives painstakingly is because this is really important in terms of how you learn something here. So the objectives for today are to help you be able to identify and describe IPT theory, to help you be able to identify the theory behind IPT for eating disorders, so getting more specific, the phases of IPT for eating disorders, and then the clinical techniques that we would use in each phase of treatment in IPT for eating disorders. So really, you should leave here with a toolkit. You should leave here feeling like you really know how manually based you might be able to go about doing this. Obviously, the clinical acumen you all come with anyway, I presume. That includes being able to conduct an interpersonal inventory. We'll go through that specifically, and formulate an interpersonal eating disorder case. We will talk in detail about the 4 primary problem areas of IPT for eating disorder. There is some argument that 5 problem areas might be relevant. That conversation will come up later. And then you will be able to collect an interpersonal incident and actually be able to role play what it would be like to do that with a client in session and what the point of doing that would be. And then perform a communication analysis within the IPT-ED framework, and then troubleshoot non-responders. So what do you do if you're an excellent IPT for eating disorders therapist and nothing's happening? Okay? Any questions so far? That was pretty straightforward, right? So what would help me is to know about you first. There's some flexibility in how I talk about this, obviously, and so it's really helpful to get a sense of who you work with, what you do for work, why you're here. So anybody that is interested, just sort of let me know. Anybody want to share?
College Counseling Center.
Okay. So you treat a lot of eating-related issues. Okay. Anybody else?
I'm with her.
With her? Okay. Okay.
High school mental health assessment clinician and screening curriculum,
Okay.
behaviors, and just what to do next.
Okay.
Whatever that.
Okay. So triaging?
For triaging and referral to treatment in the community because in the school setting, so we can guide, but I am seeing the need for a little bit more.
Good.
I'm Sarah. I work for Gateway Healthcare. I'm a program manager for one of the special systems that works with children and families. And I'm also working with Christina and Andrea with the IPT study. So we have a team that's prevented site team. So obviously, I face eating disorders every single day.
I'm working at the Providence Center, so it's a community mental health for children, adolescents, these ladies as well. We're also part of the team, Christina and Andrea, doing FPT on an outpatient basis and in-home.
Primarily restrictive eating?
Yes.
Yeah.
I'm Melissa, and I work behavioral health at a primary care center.
Oh, okay.
And actually, my first year of outpatient treatment, doing inpatient treatment, noticed that I was coming in contact with eating disorders and being a little clumsy with how to really address that specifically.
So we have, through the teams that we're working with at Gateway and the Providence Center, we've been getting lots of referrals for restrictive eating disorders, but it's become clear that lots of people are looking for options for adolescents and kids who binge eat, and there are not very many trained eating disorder professionals in Rhode Island, period, but I don't think we're aware of anybody that treats binge eating in adolescents, so that was kind of the driver for having this conference, because you really need people that know what they're doing out in the community.
Yes, yes.
So I'm Charlotta. I'm also working at the College Counseling Center as well in the EPT. So my practice basically covers like EPT, app, and so computers too, and all that
Yeah, great.
I work for Gateway in Charleston, and I work on the IHH in home health team. And so a lot of adults, there's just so many diagnoses and some of the complex.
Hi, Patricia. I work for a large counseling agency. It's private, but we just get a smattering of everything here. So it's all ages, quality behavioral health.
So, thank you all for being here. I'm really excited to share this. So my passion is the treatment of binge eating disorder and weight-related conditions. I tend to skew the opposite, so I don't do a lot of restrictive work. I do a lot of the other side, and so it's actually really exciting to be with a group who focuses in the other direction. I hope we have a good conversation. My background is in medical and clinical psychology, and I say that just because I want to know that I'm always thinking about things from a biological, psychological, social, environmental, etc. perspective. I'm sure that's how you think about things as well. But during the talk, please feel free to bring alternative viewpoints like biology and other things up, and we'll talk about it, okay? Okay. So, some training notes. This is my big disclaimer slide. There's conversation about whether they're patients or clients, depending on where you work. And so I just recognize that. I will probably use both interchangeably here. If you have a preference, please feel free to talk that way. I'm also really aware of the he, she, they gender pronouns. I will probably use he and she in this, mostly she, just because that's the majority of patients that I have worked with, although I'm really sensitive to that, and I do not mean to be offensive if I don't use they inclusively. So treatment of eating disorders and weight treatment, meaning treatment of obesity from a psychological perspective. I could do a 2-day training just on that, I think. Over the last more than a decade, I've worked really hard to sort of differentiate but also help overlap those two things, because not everyone who has an eating disorder, in terms of a binging eating disorder, has obesity, and not everyone with obesity has an eating disorder. They do co-occur, of course. So I'm just really aware of that, and I just want to make sure that you are thinking that way too. I don't mean to imply that those two are connected all the time. So as a former tutor of kids with learning differences for many years, I am also hyper aware that people have a variety of learning styles. Some people learn by listening, some people learn by reading, some people learn by, I don't know, whatever else, reading, like on books versus slides. So I've opted to have really content-heavy slides so that if those of you who have trouble following auditorily for 15 hours or get sick of hearing my voice, you have the option of looking at your slides or looking on these and reading. So that's not meant to be boring, it's meant to be helpful for those of you that might need it, but I recognize it's a lot. I hope that we will use case examples and role plays throughout the whole training. So if you have a case, ideally, there will be opportunity where you say, this is a case, and if that happens, then what I want to just remind you all is that obviously privacy rules matter. So what we talk about in here is meant to be shared among clinicians training, so I hope that we will keep it confidential, and we'll obviously use the identified case material. So feel free to use discussion, or to have discussion and questions as we go along. And then citations, so they are often on the slides themselves in small font, but if they're not for some reason, then they come from one of these places. So I have a couple of the books, I have a bunch of research articles up here. If on a break you want to kind of flip through and see what I'm talking about, feel free. And I've included a couple websites. I gave Denise Wolfley's email address up there because I can't give you, she hasn't published the IPT for Eating Disorders manual yet, but she says to contact her for a copy, so she's asking for it. So I give you her contact information in case you would like to have a copy. But I do have a copy printed here today for you to look through. So I'm trying on break to get you engaged in other ways as well. Okay? Okay, so now we get to dive in, and I'll say, much like an IPT model, the beginning part of our talk is going to be more didactic in nature. I'm going to explain some things, give you specific history and so forth, and I'm going to try really hard to use multimedia, hopefully, which means I'm going to use videos and audio and role play, so that will be less of just me blabbing up here, but the beginning is a little heavy in that, okay? So, looking at the first objective, just the theory and the history of IPT, Interpersonal Psychotherapy. So, long before IPT, Sullivan's theory was based on the concept that people's interactions with other people, so our social interactions, especially with our significant others, meaning the important people in our lives, not necessarily a spouse, but the important close people in our lives, were responsible for determining our sense of security, our sense of self, and the things ultimately that motivated our behavior. So probably as clinicians, you already understand that, but it seemed pretty, exciting at the time to be thinking about individuals, especially coming out of Freudian therapies. It seemed exciting to think about us as really interpersonal beings that relate a lot to one another. And so Sullivan asserted that people actually learn to manage anxiety and perceive people as a consequence of the validation we get from others. So that we're kind of constantly looking to understand ourselves through how we are perceived by other people. If any of you work with teenagers, you have a really good example of what that feels like. So he believed that above all else, people seek to achieve effective interpersonal relationships on a mature level. That is the ultimate goal of our lives, basically. So this is different than what had been previously talked about as intrapsychic processes, or a more Freudian perspective. This is a really interpersonal perspective, not intrapsychic perspective. And that alone could constitute a relevant therapeutic interaction. That just looking at how people interact with other people was important enough. So he also argued that people actually can't really even be understood outside of the context of their interpersonal relationships. That they're so important to us that if we're only talking about the person and what's going on inside of them without an understanding of what's going on outside, then we're not really seeing the whole picture. So he also argued that enduring patterns of relationships could either basically encourage the development of healthy self-esteem or could lead to anxiety and other mental health conditions. This was a big shift, right, away from a real focus on a person's personality to more about how the person interpersonally related. So Bowlby, as you probably know about attachment theory, so according to attachment theory, early caregiving experiences influence our adaptation or our maladaptation to our world. And that those experiences, and importantly, how those experiences are metabolized or understood, is what actually gives rise to either healthy development or psychopathology. Bowlby argued that early attachment also affects later interpersonal relationships. So our ability to attach to other people as adults is derived, at least partly, by the attachments that we had as young infants and children. And Bowlby argued that attachment bonds are actually necessary for survival. You guys have studied Bowlby a little bit, right? Okay, so this is somewhat repetitive, but. So he suggested that humans have an innate tendency to seek attachments, and that these attachments contribute to the survival of us as a species. Okay. So attachment and interpersonal processes, Sullivan, Bowlby, and others, really sort of form a foundation, if you will, for the development of interpersonal psychotherapy. And IPT was originally developed by Myrna Weissman and Jerry Klerman. And Dr. Weissman has a lot of public-facing things, so I'm going to use her voice to talk about what IPT is in its history, because she does it better than me. But essentially, this is an interpersonal triad. So again, looking at the fact that attachment, but the biopsychosocial, cultural, spiritual, vulnerabilities and strengths is all encompassing, but that distress is sort of ultimately a result of both an acute interpersonal crisis, meaning disagreements with other people, not getting along well with other people, not feeling valued by other people, and also inadequate social support. So not having someone you could go to then express, experience, process that experience. And that these factors all contribute to psychological distress, the people that we see coming into our office. I like this picture because it's a picture of the building where IPT was initially formulated, and that picture next to it is a picture of Klerman and Weissman and others looking at the research. So the initial studies of IPT were actually designed to reflect clinical practice as closely as possible. So before IPT, which is a manualized treatment, there really weren't manualized psychotherapy treatments. There were medical models where patients went in and got medication, and there was therapy, but there wasn't sort of what we now know today as evidence-based treatments. So I'm going to let Dr. Weissman explain that, but essentially there was this high contact group, meaning people who were in a trial to look at the effects of therapy versus medication on the treatment of depression. The people who, Dr. Weissman, who at the time had just finished her graduate studies, started at Yale to be the person to try to help develop this therapeutic technique. And it was initially just called the high contact group because they met weekly. And lo and behold, they decided to test it because what they found out is that, oh, people are actually getting better. So over many, many iterations, it became interpersonal psychotherapy, but it started as just a high contact, face-to-face therapeutic group. So I'm gonna explain a little bit more of that and then let Dr. Klerman talk over. So it was first conceptualized as a treatment of depression. And the treatment was compared to pharmacotherapy. And at the end of that first trial, what they found is that there was equal efficacy. And that was the very first time that something had been basically written down as a treatment approach and compared to medication. And to find equal efficacy, as you can imagine, was a huge, exciting time for people. So then what they decided is that, oh, well, if this is going to be actually something we're going to keep using and manualizing, then we actually have to test it again because drug trials require more than one positive result. So over that, they kept honing and honing, manualizing ultimately the treatment of depression, IPT for depression in 1984. As I've said, IPT acknowledges this two-way relationship between social functioning and psychopathology, and that interpersonal dysfunction results in psychopathology, and that psychopathology then results in further deteriorating interpersonal relationships. So it's this two-way street. People in depression, people get depressed in part because they're lacking something interpersonally or they're having an acute incident interpersonally, and then their depression reciprocally goes back to further harm their interpersonal relationships. People withdraw, people are more moody, and it further deteriorates that, and it becomes this self-perpetuating cycle. So we're going to listen to this. That's my dog. That's not what you're supposed to see. Okay.
Idea behind the whole idea behind interpersonal psychotherapy is whatever causes depression. It was first developed for depression. Whatever causes depression, and we know that it's partly genetic and many environmental triggers. that it occurs in an interpersonal context, so that when a person first develops symptoms, something usually has gone on in their life to trigger it. And the manual is based on understanding those particular triggers, disputes with people you love, grief, loss of someone you love, big changes in your life so that your social supports and family or attachments are dissolved. Or the more limited one is people who have difficulty forming or maintaining attachments. It's time limited, which means that the time is specified in the beginning. And the patient is taught to see depression as an illness, not their fault, but something that they can recover from. The specific things about IPT have to do with the interpersonal inventory, determining who is in the patient's life that is either a trigger of depression or else a support, and keeping the therapy in the here and now. We realize that people have personalities. We know that their early childhood experiences formulate who they are and also trigger some of the events. But we try to deal with the current event that is the trigger in the here and now. There shouldn't be holy wars about which is best. There should be available a range of evidence-based psychotherapies. Some people will do fantastically well on CBT and not IPT, and vice versa. And there are many that, in supervising residents, we go from, at the end of the IPT, we'll say, you know, maybe they should go and have some CBT.
Robyn, can I ask a quick question?
Yeah.
Keep the formula, well, the real formula, with a little help from
Yeah.
Can IPT be used for people that have personality disorders?
So, from my understanding, there's about one study that has looked at that, so basically we don't know from an evidence perspective. I've done some research on that, and
Have you seen patients with personality disorders, and is it, anecdotally, does it work at all with those patients?
I mean, in my small clinical experience,
Yeah.
I mean, obviously it depends on severity and type of personality disorder, but generally speaking, I'm much more likely to send them to a DBT practice than to treat. Now, someone who's been through a DBT protocol and feels like they can use those skills and really has a sort of a handle on that, that might be something I would try, but yeah.
Is IPT the same as interpersonal process?
Not that I know of, I've never heard it called that before, but.
I know a little bit about that type of therapy. There are like some similarities. Like I think in IPT you focus on the relationship with the therapist sometimes, and that's like a big part of interpersonal process therapy. But this is definitely distinct from what most of us, at least anybody that's trained in like college counseling centers or been in that world at all, thinks of as interpersonal therapy. It's different. There are similarities, but major differences. This is much more structured. This is like the Irving Yalom type stuff, yeah. Right? That's what you're referring to?
Yeah, I'm just curious about it. We have someone who's very into college counselling, very into interpersonal process, and I just don't understand the difference.
Yeah. I think this treatment focuses more on relationships with others, whereas that type of treatment kind of sees the relationship with the therapist as like a stand-in for the relationship that people tend to have with others, right? Yeah.
Yeah, that helps me. So we will talk about that a little bit actually, and how we use the interaction in the therapy room. So that does happen in IPT, but again, in a sort of structured way where we, and I'll give you a case example later on about how in a session with me, a client had an experience and sort of we talked about that as an example of what might happen outside. So interpersonal psychotherapy, particularly in group, sees the group as a little interpersonal laboratory. So it probably overlaps some from questions in that break, that really helped. IPT has been adapted outside of just depression, obviously, since I'm standing here talking to you about it today. But originally it was developed, as you know, for middle-aged adults with depression, but it's been extended to other life groups. So it works exceedingly well, and the work I did with Marianne years ago was with adolescent girls who were at risk of obesity later in life, so they were a little above average in BMI, and they experienced loss of control eating. It is the most, I loved it. I loved being in IPT, using IPT with adolescents, because talk about a group where interpersonal relationships are hot, right? And their buy-in is huge because they are so aware of how important interpersonal relationships are. So I love doing that. Women around the issues of pregnancy, obviously the transition of becoming a parent is huge for people, and so that major life transition can trigger, as we know, postpartum and relationship issues with spouses or partners or family members. So that's another group that seems to have a lot of buy-in for the use of this work. There's some evidence that people who are later in life, so again, you can imagine a period of transition where people are retiring, people are leaving relationships, maybe after a kid goes to college, there's a divorce, or people have lost a partner, death. So these are, again, major life triggers that have to do with interpersonal experiences. People and friends start to pass away or move to retirement communities, so there's a lot of change going on. Other cultures and countries, particularly where there's low resources for mental health, and cultures where interacting with community and family is of high value and high priority, IPT has been shown to be effective in places, so Ethiopia, Uganda, other places. And then, of course, as I mentioned, it's been adapted for group format and even a brief format. So getting adolescents to buy into 20 weeks of treatment. If you can adapt it to maybe 12 or something like that, then there might be potential for that to go, to be effective. And then, of course, what we're here to talk about today ultimately is the treatment of eating disorders. Because I know that people learn by repetition, you'll hear me say this type of thing a lot, but the basic concepts of IPT are that we reduce symptoms still in sort of broad picture IPT of symptoms of depression, which is primarily what it was used to treat, by improving people's social and interpersonal functioning. So often, we're not in couples therapy, we don't do family-based therapy, so when people come to you in practice, usually what they're coming to you saying, if you're working on depression, is, I'm depressed, or these are my symptoms. And so our job when we're using IPT, or for that matter, any evidence-based treatment, is to sort of zoom out from there, right, and look upstream of that and figure out what's going on that is fundamentally triggering what they're presenting with. So in CBT, where we might talk about negative automatic thoughts and core beliefs and other things, in IPT, what we're going to do is immediately start honing in on interpersonal relationships. What's going on in family, what's going on in peer friendships, what's going on at work with bosses, colleagues, other places where you have a lot of intense interpersonal connection, or you don't have enough interpersonal connection. So, let's say a person who was divorced and had to move and now has very low social support. That's another place, obviously, while we can't say, oh, it's a disagreement with person X, it's a paucity of relationships, loneliness. So we would address that as well. As Andrea alluded to, IPT is a structured program, and by that I don't mean it's cookie cutter by any means. I just mean that there is a plan. And the plan is to, right from the start looking at the interpersonal triggers to what you're seeing in front of you, and that you focus on the current, present day functioning. So that's complicated, and I really want to talk that through during the next day and a half, because obviously I just talked about attachment and how important that is. So there are patterns of behavior that people learn over time, or traumas that people have experienced in their history that obviously impact their present day functioning. But if you're looking at IPT, what we're really saying is we're going to spend less time focusing on what happened to you in the past. And to quote Dr. Weissman, instead we're going to rescue your future. So we can't blame your past beyond acknowledgement that that has an impact on where you are today and what is happening for you today, but that it's your job as the patient to rescue your future, to make changes actively, proactively to improve your relationships and therefore your mood or your eating disorder. So there's a structure and the flow, not just of the sessions across weeks, but of the session within a session. The flow matters. I remember in graduate school watching these CBT sessions and, agenda setting and all of that. Do you guys remember that? So it's a little bit different than that, but I am going to either read through examples or we can even role play examples of how it might go. And what are the important takeaways when you bring your own clinical style to this? What are the takeaways in terms of how do I structure an IPT session? The therapeutic stance, and I'll actually be really interested to hear if this is how you see yourselves, but is a really active, engaged therapist. That's different than the, sort of more passive, blank slate therapist, or even just the supportive therapist. All of them have a space. It's just in an IPT role. The therapist role is very active, very engaged, problem solving, talking about, what about this, or how do you link that to this, and so really active. So how many of you would say that's your general default style anyway? Okay, so it'll be right at home for some of you and a little stretch for others, and that's okay. Okay, any questions so far? Yeah?
When you work with little kids, how do you apply that? Because kids don't tend to talk much. So how you, in one way or another, include some activities or something like that in order to continue the structure?
That's a great question. So I don't work with little kids, and as far as I know, IPT has really been studied mainly in adolescents. So I think using it as an evidence-based treatment, it would be done just with adolescents who are usually more than willing to talk about relationships, important relationships. But does anybody else work with kids that has, who else? Anybody else work with kids in here?
I work with kids, but I haven't used it.
Haven't used it,
Yeah,
yeah. Maybe at the end of day one, let's talk about that again once you sort of have a sense of the tools that are there, and I'd be really interested to know what you think. Yes.
Have you done any research on how it works with adolescents on the spectrum?
Personally, no.
Or have you seen any?
Have I seen any? So there is a little bit of a discussion about autism related. So when there's a low need for social relationships, which isn't necessarily all spectrum related, but basically the nutshell is that IPT doesn't seem to be effective for clients who present with a low need or a low drive for social relationships.
I feel like kids on the spectrum might have a hard time identifying the specific domains aside from I don't have a lot of friends, right?
And emotion identification and expression is challenging, and really IPT is really working on building affect regulation and acceptance and experience. So I could see it being hard. Okay. So we're going to go into these in detail. Is that right? Okay. So the IPT problem areas, which is basically just a case formulation conceptualization, and what you would openly share with your client so if you did a lit search on IPT problem areas, you would see that the majority of studies suggest 4 problem areas, and they are grief, role disputes, role transitions, and interpersonal deficits. So if you leave here today thinking that those are the primary problem areas for IPT, you're right. You will also see research studies that essentially leave out interpersonal deficits. We'll talk a little bit more about that, but essentially the idea that some people that have interpersonal deficits are people that have a low drive for social relationships. So is it even really an effective treatment is to be questioned. So how you interpret interpersonal deficits matters. So when we dive into interpersonal deficits, what we're really talking about are people that have both the capacity for close interpersonal relationships and the desire, but for one reason or another haven't been either successful in having them or have had a major life event that has reduced that support. So, for example, someone who has dysthymic disorder and depression and has withdrawn for several years and has a really low social support network, but used to be, I don't know, like in a sorority and have close friends and other things. So that person is very different than someone who's on the spectrum who has a low need or has a personality disorder that has a low need for closeness. So I think that's maybe part of why there's that discrepancy. And then Rebecca Murphy out of Oxford talks about we should actually include a fifth problem area, and that should be considered a life goals problem area. I will tell you, in clinical practice, I could not agree more. This problem area, which is not really well sort of flushed out, and you have to dig for it a little bit, really hones in on the idea that some people, when they have long-standing eating disorder or depression, are just sort of not achieving things in their lives, right? So they're, maybe they got through college, but they've been struggling to launch or to get a career, or maybe they have a strong desire to start a family, but they've sort of not ever tried to date for the last 10 years, and now they're turning 40 or so. I mean, I see that all the time. So to me, that area, even though there's not much research on it, so I don't spend a ton of time, I would love your feedback on it because to me it's really important.
That reminds me of like an existential, like a meaning and purposelessness
Yes.
pillar of existential psychology.
Yes, exactly. And I think, so that gets in a little bit around role transitions as well, particularly for things like retirement, where people's whole identity, I live in Washington, there's a lot of career identity people there, as you can imagine. So retirement is like this sort of dropping out of the purpose in life. So to go back to the objective, oh yeah, please.
This is going to sound like a silly question, but I'm not quite getting what the problem here is. Like, what do you mean by problem areas?
That's not a silly question at all. So if I was conceptualizing a case in CBT, I might say that this person's major issue is cognitive distortions around black and white thinking and something else. And that those are really going to be the primary focus of our work, that we're going to keep interpreting what's going on in their mood and in their lives from that perspective. In IPT, instead of it being about cognitive distortions, it's about particular sort of like catch points in relationships. And those are, maybe it's grief, so the loss of an important relationship. As we go into grief more, I'll describe death versus loss a little bit, but it might be a dispute. So this is a classic one with like adolescents and their parents. The adolescent is trying to sort of differentiate and grow, and the parent wants to keep close tabs. We would conceptualize that as a role dispute. So when you're in treatment with that person, we're conceptualizing like this is the primary factors that we're going to keep working on to improve to minimize the role dispute that you're having with your mom or your dad, and that those improvements will help improve your mood or help reduce your eating disorder symptoms.
So it's a problem area for the patient.
For the patient, exactly. Yeah, so IPT conceptualizes each patient as coming to you with usually one, often two, primary problem areas. How you conceptualize that is a little bit of clinical experience and acumen, and honestly, if you get, I don't think there's like one 100% right answer, right? There's got to be a lot of overlap here, and so I think to me the most important thing is making sure you're communicating it to the patient, and that he or she sort of gets it, buys in, agrees that that is truly a catch point in their getting better, and that you two collaboratively work on improving it. So whether it's a transition or whether it's a role dispute is important, but probably not. Okay. Other questions? Yeah.
When you have a client that has more than one problem,
Yeah.
how you prioritize which one you start first? I mean, depending on the,
Yeah. So her question was, if you have a client with two problem areas, how do you prioritize which one? And so to me, that's just an example of talking to your client. Like, you have these two big things going on, and which one do you want to start with? Or from a clinician standpoint, which one do you think is more likely to actually make a difference? So if the patient comes in and says, you know, oh, I just graduated college and now I'm feeling like I'm sort of floating and I don't really know what to do. That's a big transition. That could be triggering a depressive episode. It could be triggering binging. And then you guys can work on that. But they say, oh, and, you know, for the last 5 years, my mom has, you know, continued to treat me like I'm 14, even though I'm now 19 or I'm now 22 and I feel really independent. I might consider which one of those is more likely to sort of move forward a little bit, because again, that sort of gets patient buy-in or connectedness to you. They feel like, oh, I'm actually doing something. But we'll talk, as you see the problem areas in more and more depth too, I think you'll have a better understanding of what that means. So I'd like to just spend a few minutes talking about what makes interpersonal psychotherapy unique compared to other evidence-based treatments. So first, it's fairly time-limited, meaning it's not long-term. It's not 10-year therapy, but I don't want long-term to confuse you because maintenance sessions can last several years for people. So it's not like you have to throw them out the door at 20 sessions and say good luck. There is a maintenance component to this, and I do a lot of that, and so we'll talk through what that looks like. But the sort of manualized part of IPT is essentially a time-limited treatment, something like 20-ish sessions. There are distinct phases in IPT. There's the initial phase, where we do essentially an intake, but it's called an interpersonal inventory, including an interpersonal closeness circle and an interpersonal timeline, particularly with eating disorders. I love the timeline. I think it's really helpful around binge eating and things to sort of really get a sense of what might be triggering the onset of this type of behavior. And then it moves into the work phase or the intermediate phase. So after a few sessions where you've really gathered a lot of information about the person's relationships, what are triggering things, and created an interpersonal formulation, then you make a point of explaining to the patient. First, from the beginning, you talked about it as a time-limited treatment. And so you make a point of marking, okay, so we're sort of wrapping up the initial phase, and now we're moving into a work phase. And the point of that is to, again, give responsibility to your patient. Give responsibility to the client. Like, this is not ongoing 10-year type of treatment. This is really your responsibility to use these tools to go out in your life and make changes. And then hopefully people start to see improvements in whatever they're experiencing during that work phase. And they have you, I always like to frame it as, like, we have this really unique opportunity to really dig in and understand these interactions or these arguments or these things that are upsetting you and slow them down and talk them through in a way that most people never get. So let's take full advantage of that opportunity while we're together, and that's the work phase. And then you go into a termination phase, or as some people call it, a conclusion phase. Maintenance is the possibly for phase. So it's typically a focused type of treatment. So again, you identify for the patient and with the patient collaboratively what their primary problem areas are. And then you together work with them on these particular issues. And it's a manualized treatment, so you have a plan and a protocol for delivering treatment. And we are really staying in the present. So we're really focused on the current interpersonal issues that the person is experiencing, and that are contributing to the person's mood problems or eating problems, and using that. So, you know, a person can come in with an argument they had with their spouse yesterday or that morning before coming to you, and that's awesome. I'm so excited when someone has something really fresh like that because their affect is still high and you can really get some good work done. So in the initial phase when we're doing the intake and really looking at these relationships, of course history comes up, right? And we want to know that. We want to know the historical context, but really so that we can understand the present, not so that we can process what happened, except in the case of grief, and I'll talk to you about that in a minute. I already mentioned that it has an interpersonal focus, not an intrapsychic process, and so we focus on these interpersonal relationships, even if we're aware of defense mechanisms and other things, if you happen to be trained in that modality and that's something that you conceptualize cases through, it's not like you should throw that out the window, but it's just that it's not a primary focus of how you're interacting with a client. It's certainly important in terms of how you're thinking about, you know, your experience sitting in the room with a client and other things, especially if you move into maintenance treatment. But in general, when you're interacting with a client, you're really focused on the skills and strategies that I'm going to present to you here, the tools of IPT, if you're doing it from a manualized, evidence-based perspective. Personality, so interpersonal, not cognitive behavioral. So IPT and CBT, I would think of as like first cousins. I don't know what Dr. Weissman would say about that. But to me, they're related. I mean, and maybe that's just because that's how my brain works. I can't help being a CBT therapist too at heart. But it's not CBT, right? So we're really not saying to people, these are your cognitive distortions, or let's look at your core belief structures and other things. We're really talking about relationships. But of course, there are all sorts of cognitive distortions going on in relationships. And so in the course of role-playing with someone, an argument they have with their spouse or something, it's probably going to come up if, for example, they're saying, you never, blah, 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 that's going to come up. So that it could sort of be a cousin to CBT that way. And especially if you're treating binging or other things, sometimes people want to self-monitor their behavior. And that's a very classic CBT thing, right? So sometimes self-monitoring their binges or self-monitoring the triggers to their binges. So using tools in that way, it's related to a CBT approach, but not exclusively. We don't really focus on personality during the treatment. We experience their personality in treatment. And then again, it's less interested in causality of like what originally triggered your depressive episode or your eating disorder, although we like to know that across the span of a life timeline. In treatment, what we're really doing is looking at what is maintaining it, what is going on in the here and now that is exacerbating this. Okay, so the role of the therapist. Okay, so the role of the therapist in IPT, and I'd be curious to hear how you guys respond to this, but it's really an advocate for the patient. And we really go in with the mentality of like, you can get better, you can do this, you can make changes that will directly impact your mood or your eating. So that's not neutral, right? That's really an active, engaged advocate for the patient. And I personally find that really positive. Patients respond remarkably well to having someone that they basically feel like has their back, is on their side, is helping them make real changes. So I don't know, does that sit well with you guys? Does that make sense? Yeah? Okay, good. Our stance, of course, is non-judgmental. I've sort of built my whole practice on non-judgmental approach, that if a patient perceives judgment from us, I just think the therapeutic alliance is really affected by that negatively. So I try very hard to, I don't care if the patient's talking to me about the, 13th affair he's had on his wife. Like, it's not my job to judge that. It's my job to work with that patient in the sessions about what's going on. And because of that, patients feel surprisingly open to talk about things that they've never talked about before, because having a non-judgmental person goes a long way. We have this sort of unconditional positive regard, warmth, really connectedness. And so it's been stated that IPT therapist is a benign and helpful ally. So like I'm in your corner. When we use confrontation, it's not really confrontation. It's more like, let's look at what just happened there, and how do we change that so that you feel better? Or how do we change that so this relationship goes better? Or how do we change that so that you don't have to go binging, 15 minutes after that happens? So it's really confrontation, I would say, more like targeting and saying, So when I hear you say this, for example, you know, I don't know, this comes to mind or something, or how do you think that might be received by the other person? And we do some role plays, and we'll go into really specifics about that. So we're focused on the therapeutic relationship and not necessarily the transference and countertransference that's going on. But we are focused on what a patient's doing in front of you and how the patient is talking to you is probably how the patient is talking to people in their lives. So you can, after you have a good therapeutic connection, gently point that out, especially if it's, you know, if the patient never makes eye contact, for example, or only refers to him or herself in the third person. You know, like there's all sorts of things that happen in therapy that we can talk about. So we are directive, we are offering reassurance, and at the same time, really fostering a patient's sense of competency, that you've got this, you can do this. We are going to build skills together that are going to make it possible for you to do this in the real world. And we're going to practice them in here so that when you actually go out in the real world and try it, it's not the first time you've ever done it. And if it goes awry, then we'll figure out how to try again. So that's sort of the general attitude in the room. And it goes without saying, it's therapy, not friendship. But you'd be surprised how quickly patients want to befriend you when you are a benign and helpful ally. Because having a non-judgmental person talk through your feelings, it's really easy for patients to want to be a friend. So again, we're active and not passive, but particularly in that we keep putting the responsibility back on the client. We keep saying, you know, the ultimate responsibility for change lies within you. And while we're fostering a sense of competency around the ability to handle that responsibility, we're giving the ownership to them. And the goal is ultimately to help patients learn how to do this in their real lives in an ongoing way. So if we're talking about the dynamic between a patient and her roommate, for example, then ideally she learns enough about communication and so forth that she can then use those strategies with a future boss or a future colleague or a parent or a sibling or other people. And you can explicitly say that. So we provide reassurance, and then we help to work with patients to help clarify their emotional states. So I just had a patient for the first time say, I think I understand the difference between feeling calm and feeling numb. And I thought we should like have a party. I don't know, I felt so excited for her because when you use binging as a primary means of calming, it's really confusing to know those two differences. So we're really working on identifying what does it feel like to feel numb, and let's not mislabel that as calm. Right? It's really different, two different experiences. We also really actively work with patients to help them improve their communication skills. So this one is tricky because particularly patients that have high sensitivity to criticism or negative feedback, you have to use your clinical intuition to know how to talk to patients about improving their communication skills without them hearing you stink at communicating, right? So that's something we're going to spend a lot of time on and even practice, because that one's tricky. And then we actively test perceptions and performance through the use of role plays. So we're going to do a lot of, you're going to watch a lot of role plays. We'll do some in here. I'll read you some examples of role plays. I'm trying to get every mode possible to help you experience what it's like to do that in a session. So because we are showing warmth, support, and empathy, and we're not neutral, and our discussions, we phrase our discussions in a really positive way. So going back to this idea of, I would never say, you know, that communication that you just used wasn't very effective, right? Even though that might be what I was thinking, like, wow, no wonder that person doesn't get, you know, good feedback from their spouse, if that's how you communicate. Obviously, you have to sort of use clinical judgment in how you communicate to the person so that he or she doesn't feel judged or wrong. This is particularly critical when you come, and people who work on restrictive eating disorders, you probably know this more than anyone, when you come from critical parenting situations, and if anybody has patients that have a history of weight problems, then there's a lot of criticism a lot of times from the family. So me, as a therapist, I always am very aware of how I'm saying things, because it can be just the slightest tone of voice or the slightest eye contact shift can be misperceived as criticism, and that's a therapeutic issue. But something you should bring up if it happens immediately in the session, so don't shy away from it. So we have this sort of hopeful, positive, optimistic attitude about your patient's ability to recover. Sometimes just that goes a tremendously long way. Just the idea, I have a problem and I know how to fix it, or I know I have tools to fix it, is such a relief. I'm going to read to you a little bit later a snippet of a de-identified case. It's a journal entry, one of my clients, from maybe about 5 years before she sought treatment. And it's just, it'll be so fascinating, because this idea of identifying that you have binge eating disorder, just that is like, oh, I'm not completely crazy. Okay, it goes a long way. So throughout today, I'm going to rely on Jamie Young and Laura Muffson a lot, because they've done a lot of work in IPT for eating disorders. I'm going to show you some videos of them and so forth. And one of the videos I'm going to show you is a role play, or several of them are role play type things, but in their training, they put up this slide, and so I'm borrowing it from them because I thought they did a nice job of breaking it down. And so the primary components of IPT are education, meaning we provide psychoeducation around, for example, the eating disorder, right? What is the eating disorder? What is the diagnostic criteria type thing, like have a discussion about eating disorders, or depression, or whatever you're treating. You give them what's called a sick roll. We'll talk more about that, and I love your reactions, because when I first read that, I was like, what? I didn't like that. Or a modified sick roll. So in IPT for eating disorders, it's been discussed that we should actually sort of modify the sick roll a little bit from depression, and I'll talk about that. And then we do a treatment contract, so that's also considered a psychoeducation component. And that's really about educating the patient about what is IPT. So this is a type of treatment, and this is typically how long it lasts, and these are the 3 phases, and then if we need maintenance at the end, we're going to recontract for that, and so on. So really providing a sense for what's going to come down the road. And then another component of IPT is affect identification, so helping your patient label his or her emotions in session. You know, what was that feeling you just had right there? I don't know. Or stress. How many of you have stress as like the primary feeling response? Yes. And do you guys help patients with that? Do you talk about that? Yeah. I think that we don't have any words for we have emojis. I'm not kidding. Like my patients can actually say to me once, if I could show you my emoji, I would be able to show you what I was feeling. Which I guess isn't that far off in the feeling spaces, right? I thought of that before. Okay. We also facilitate the expression of emotion. So people who don't typically cry or don't typically express anger, we help them in the session to express that, actually feel it, see what it feels like to tolerate the peak of it and then watch it subside. And even just that experience for a patient, as you know, is enormously helpful. The idea that you can experience something really intensely and then it dissipates. And then we monitor emotions in an ongoing way. And then another component or pillar of IPT is building interpersonal skills. So not social skills training per se, but helping people become more effective in their interpersonal relationships. And how do we do that? First, by modeling. So remember that when you're in a session with someone, I mean, this is across all therapies, I think, but people are looking at how we interact with them. And so in IPT, how you communicate, for example, we'll talk about some communication skills, but if I were to say, you know, you said this and you sounded blah, 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 it doesn't mean the same thing as if I said, well, I felt a little confused when you said it this way. Because, so we're modeling the use of I felt confused. That's a big piece of the puzzle. So we'll talk more about that. Using the therapeutic relationship as an example of an interpersonal relationship, and as I mentioned, I'm going to talk about a particular example. Communication analysis. We're going to go through explicitly what communication analysis means, how to do it, some questions you might ask, like actual questions that you can jot down and take with you. And then perspective taking as part of role playing. We're going to talk about what it's like to do a role play where you play the patient as opposed to the patient playing the patient and you play the other person, and what the differences are when you do it like that. We're going to talk about interpersonal problem solving. So particularly if you're working with adolescents, although quite frankly for adults too, sometimes they have really no idea how to go about this differently. And so we might have to really work with them to develop some ideas. And so that's a very appropriate part of IPT, getting really active and engaged in helping them establish alternatives. And partially we do that through role play. Okay, so I'm going to do a very brief overview of the treatment literature, very brief, but just know that the APA and the World Health Organization have both consensus treatment guidelines. They've included IPT for the treatment of depression, eating disorders, bipolar, PTSD. It doesn't appear to be particularly effective for substance use, and Dr. Weissman says that it's probably more useful, probably like personality disorders, sort of after someone has gone through appropriate substance abuse treatment, then might be the time. So you wouldn't treat the substance use disorder with it, but you would treat the resulting impact on relationships that probably occur when you have a long-term substance abuse problem. So I'm going to let Dr. Weissman talk for maybe just like 5 minutes here about the research review.
We're given an 8-week course and see what happens.
And is depression the only condition that IPT is used for?
Well, first of all, for depression, there's
Your dog is very articulate.
showing its efficacy and
So it's just an audio. I'm sorry, I should have said that. It's a podcast audio. And that's my dog, Zico. He's very sweet.
lesson in geriatric depression. There's actually books on adolescents and geriatric depression using IPT. It's been used in primary care. It's been used with pregnant women and in the postpartum period. So it's been used as maintenance treatment as well as acute treatment. It's been used in HIV patients who are depressed and in other patients with medical illnesses in primary care who are depressed. So there's a whole number of studies with different types of patients who have depression. Now, it has been less well tested with other disorders. There's good studies with bulimia, which showed that it was effective. And there's 3 studies with drug abuse which showed it wasn't effective. So we don't recommend that depressed drug addicts get IPT. In fact, they didn't want to take it. There's some studies with anxiety disorders with PTSD, but they're not very large studies. There's one with social anxiety disorder, which may or may not have been published recently. I think it hasn't. So the evidence there is, I'd say, less strong. Now, there is a good study that used IPT as adjunct treatment for bipolar disorder. And in that study, they used IPT to help to modulate the patient's rhythm, social rhythms. Because if a person has bipolar disorder, and they also are subjected to a lot of stress, such as either the stress of international travel and jet lag, or the stress of a new job, or the stress of something in their life, they're more apt to be thrown into a manic episode. And what this does is help the patient to monitor those social rhythms. And IPT is used as an adjunct treatment to medication. It's not recommended that it be used instead of medication.
And well, it sounds like there's been a lot of research done on this, so it must have been around for a while. How long has IPT been around?
Oh, it started about 30 years ago. It was part of the first study by Jerry Claremont to look at maintenance treatment of depression using drugs and psychotherapy. And at that time, the only treatment had been formalized was CBT by Aaron Beck. And Jerry thought that, well, Aaron Beck had done a marvelous job in spelling out in a manual what the procedures are for CBT. Most patients were not getting anything like CBT. They were getting something called supportive psychotherapy, although it wasn't clear what that was because it wasn't spelled out. So what he wanted was a treatment that would be more consistent with general practice.
So just a very brief opportunity to, I think hearing Dr. Weissman talk over me, she's the IPT founder. Okay. So now we're going to start getting honed in a little bit, but before we get specific, I just want to remind you that the tools of IPT, in some ways like the tools of CBT, are transdiagnostic. So once you have this toolkit around eating disorders, theoretically you could treat other things as long as it felt within your clinical purview to do so. So we're going to spend the next just 15, 20 minutes or so doing an overview of the theory around IPT for eating disorders, a little bit of the research, and then we'll take a break and we'll dig into the actual content, okay? So the theoretical underpinnings here are, not surprisingly, the idea that eating disorders develop within social and interpersonal contexts. That if everything was going perfectly in a person's world, he or she might not develop an eating disorder. And that the relationships between the patient and significant others impact the onset, maintenance, and treatment efficacy, and of course, relapse response in an eating disorder. So that those interpersonal relationships are critical across the span of the disorder. And in this case, significant others are defined as nuclear family, extended family, close friendships, and that's really important for adolescents because as we've learned over time, and if you sit with adolescents, you know that someone might not have to be a close friend to be an important trigger in that person's life. So I'm going to talk a lot about the difference between close and important and how you talk to people. But work relationships, and that doesn't have to just be the work husband or, right, it can be the colleague who sits in the queue next to you that you have to sit next to for 9 hours a day every day, even if you're not really friendly with them. But those can be really impactful triggers to people. And then obviously neighborhood, community, church, etc. And so the focus in terms of the theoretical underpinnings of IPT for eating disorders is that it's our job to help identify and modify the interpersonal context within which the eating problem has been developed and is maintained. So when we talk about adapting IPT as it was developed for depression and adapting it for eating-related issues, here's what we do. So we focus on the current interpersonal problem, just like in depression treatment. The difference is that in IPT for depression, there is sort of a focus on you became depressed when X happened in your life. And with eating disorders, while yes, we do relate to the onset, so for example, it's not uncommon in treating binge eating disorder for the person in front of you to have started binging in early adolescence, 10, 8, 11, 12, something like that. But now the person's sitting in front of you at 25 or 45. So it's important to understand that past trigger, but really to work on the present, what's going on now and how that became a learned response, essentially. As I mentioned before, in a specific adaptation of interpersonal psychotherapy for eating disorders, this proposal of that 5th problem area has been proposed, the life goals problem area. and we'll talk more about that. It's not really been fully integrated. It's not part of the manual, for example. I think that we should talk about it, and I think you should consider it important in your clinical work. When you're using IPT for depression, we are really focused on, people's mood changes, right? So depression has its sort of natural linear course of up and down and onset and remission a little bit in depressive episodes. And with eating disorders, we're less focused on that. We're less focused on the day-to-day fluctuations of the eating experience beyond phase 1, because what we're really trying to stay focused on is the interpersonal context. And it's so tricky, especially when you're treating people who have a combination of obesity and eating disorder. It is really tricky because people get lost in the work, in the discussion, the thinking around the eating behavior or the body image. And so in IPT for eating disorders, we're actually not really talking about that. So we're redirecting to the interpersonal context. And I'd love to hear how you guys feel about that, because I know it can feel like we're not meeting the patient where he or she is, that whole thing, because they really want to talk about the binge that they had, or they really want to talk about how uncomfortable they feel in their body. And it's complicated to both acknowledge and talk about that, but to keep redirecting to the interpersonal work. And that's why if you start from the outset with the idea that this is a time-limited treatment, then you have a little bit of something to fall back on of, we have this limited time together, let's really dig in and make changes that we know are resulting in what you're experiencing sitting here today. So let's keep going upstream.
Yeah. So with that focus, and with eating disorder and obesity, have you ever in your experience seen where you get into through phase 1 or beginning phase 2 and recognize that this is just not working? Or something happens? I'm just wondering with the eating disorder focus and body image issues, because it ever is.
Sure, yes, because nothing ever works all the time. But I would say that if you do a really thorough job of explaining what the point of treatment is in phase 1, and keep circling back, that if a patient doesn't want to do that, they're not going to continue treatment. So there's like kind of a clinical negotiation, I think, in the beginning. It's not like they're mandated. At least I don't work with people who are mandated to get treatment with me, so it's not like they have to show up for 20 sessions, and I'm really honest, like if it's not something they think they want to do, then go with somebody else. Yeah, I refer appropriately. So, and as Dr. Weissman alluded to, that sometimes people who will do really swimmingly well in CBT, if you're a clinician who is versed in CBT, there's times when I just know that the person in front of me would benefit more from CBT than IPT, and I will talk to them about that. We have these 2 different types of treatment. My clinical gut is telling me to go this direction. I just have that conversation. Yeah, okay, thanks. And then the sick role. So in IPT for depression, we talk about the diagnosis of depression. We talk about what it means, and the point of the sick role is to mimic the medical model. So you have diabetes, and this is the treatment for it. In depression, you have depression, and this is the treatment for it. And you have permission, number 1, to work on your depression, right? This is not something you should just fit in around the edges. This is your job is to work on treating this depression. And I'm going to give you the tools to do that. And this should, in depression, this should become a priority over other things in your life. Meaning, if you're struggling to get out of bed, then we need to be actively going after your depression in a way that's going to get you functioning again, right? So it can't be something you sort of think about in the 4 minutes before you come in to see me. It has to be the priority in your life. With eating disorders, it's a little more complicated, especially around binge eating and other things, because, so I think I read a study that said that people with binge eating in particular, which is my expertise, have often been experiencing binging for upwards of like 8 years before seeking treatment the first time. And I think that's partially because people just think there's something wrong with me, or I'm just lacking willpower. There's, as you know, society has so many biases around eating behavior and around people's self-control and all of this around eating and body weight. So I think people, I think they don't want to come to treatment, or they don't think that binge eating disorder is a thing, and since it was just actually in the DSM-5, they are far off from that. So in eating disorder treatment for IPT, yes, we say you have X, binge eating disorder, or you have an eating disorder NOS or something, but I don't really talk to them about like taking time off work to treat this or anything. I really actually sort of do the opposite. I really talk about how we have to learn to integrate treatment of this into your real life, because you've been living with this in your real life for the last 2 decades, for example. And so I really want to help people learn how to do these skills regularly. Yeah.
Just thinking about the hiding or the not going to treatment, what do you do with the shame?
So this word, shame, is in every session, in every room I've ever been in treating someone with an eating disorder. Now, I don't work on the restrictive side. I'm sure it's there too. But I think it probably does take a different form. And I'd love to hear from people that treat the restrictive side. My experience on the other side is that, I've even had people say, if I was going to have an eating disorder, I wish it was anorexia, because at least then I'd be thin, right? At least then the world wouldn't look at me and think there's something wrong with me. I've had clients say, you know, my body, it's like if everybody had to wear a t-shirt that said what they struggle with, you know, like, oh, I cheat on my taxes, I cheat on my wife. Well, if you had to wear your vulnerability out for the whole world to see all the time, that's what it feels like to struggle with an eating disorder that results in or is comorbid with weight gain. And so the shame is palpable. And I just talk about it straight away. So Andrea mentioned the online coaching program I do. It's like a 6-week CBT-based program. And the whole week 1 is about internalized weight bias and shame and how much that impacts our capacity to heal. And so I talk really openly with clients about it and sort of keep coming back to it, because I think having a place where they are acknowledged that, yes, society does really stink, right, around, and I mean, yes, is there improvement? Sure, but it's far away from acceptance. Families don't accept it. I've had parents, you guys probably too, call me and say, like, my daughter's fat, like, make her lose weight, help her lose weight, do whatever you can, right? She's gonna live this horrible life if she looks like this. So if they're telling me that, imagine the messages they've given that kid over the last 20 years. So shame, I mean, that is a discussion. How do you guys handle it? I'm sure you experience it with everything you treat too. How do you talk about it?
I do like of RCT, and that you contextualize it of eating disorder, and really stressing, you know, what the pure culture does, for white people, not so much. I do know what sorry.
It's okay.
I'm into self-compassion and compassionate working with that. I like the idea that it uses the that it's
A verb, yeah.
action.
Yeah.
Ultimately. And that seems to be maybe, I'm going to be just starting to work on that, as it seems to be,
It's a slightly different question, but what do you do with, what do you do with patients that may hyper-identify as being sick? How do you address that?
So, can you give me an example?
Yeah, so in eating disorder, patients sometimes they may stop and sort of sick, and sort of thinking more like vaccines.
So I'm curious to hear about, from people that work in restrictive eating, what you think about that in the world that I work in, the more binge eating, emotional eating. Sorry, yeah, the question was, what do you do with patients that present and are sort of stuck in the sick role? So have hyper-identified as having anorexia nervosa or being anorexic. And I'm curious to hear your thoughts about that for people who treat that. So I know, Christina, you do that. Do you have any thoughts?
So I think that's a tough place to be, and I think one of the main tenets of FBT, family-based treatment, is to externalize from the illness or differentiate from the sick role. And because we're, in FBT, the focus is on the family and not just the adolescent or the teen, we're encouraging parents also to externalize, which decreases shame as well as blame, around the child being stuck in an illness. I don't know if you'd add to that. And I think that's one of the big main tenets that is really, really important. Teenagers, of course, in my clinical experience, anecdotally, they either really engage in the differentiating and they're like, I get it, and I want to call it Ed, or I want to call it the body bully, or they name it and they own it, and then other kids are like, F that, this is me, I don't understand what you're talking about. So as an intervention, I think you have to think thoughtfully around, you can't just use a blanket intervention if it's not, working. But for parents, I think universally for parents, it's driving home that their kid, you can't expect your kid to make decisions rationally when they're in a saturated self-starvation brain. And if we shame the kids or blame the kids, it's just going to perpetuate the illness. Yeah. I was just thinking, I feel like it's so different with restricting than binging in terms of I think with restricting the sick role, they actually look sick sometimes, and people are they look fragile, and they do internalize that. But with sort of the binge eating, I don't know that society looks at them as sick. It's it's sort of like you said, you don't have a lot of control, you don't have a lot of willpower, and they blame them even more. Yeah.
Exactly.
Yeah, so I feel like they don't get people with the binge eating and the obesity. They don't really get that oh, I'm in the sick role and I sort of want to stay here. Sometimes in restricting, they sort of want to stay there sometimes.
Yeah, I think that's my gut reaction to that. This is where there is a big difference in the type of eating disorder. But I will say, independent of eating disorder, people who have lived in larger bodies their whole lives, certainly that's a discussion we have. Is if someone is doing weight management and losing weight, it does change their identity. People will say to me things like, I was always the overweight kid growing up, so I learned to be really funny, or I learned to be really smart, or I'm always the one that has the nice shoes, or things like that. So there is a different, there is identity discussions around weight change, but I do feel people rely on binge eating in my clinical experience because of the beliefs they have about what binge eating does in terms of the numbing and the escape of negative affect. But they don't want to be doing binge eating most of the time. There's not a lot of, society doesn't reward or reinforce it in the way that it does weight loss if you're restricting. So I do think there's a difference there.
I also feel like, not so much with adolescents, but with the adults, often they've had binge eating disorder for so long. They've tried every single diet and treatment out there and nothing's worked. So I think there is even though they don't want to have the eating disorder, I think a lot of people come in with this belief that well, this is just the way I am and this is just the way the rest of my life is going to be, and I just need to accept it.
Right.
Yeah.
Exactly. Yeah. So I think what we're gonna do, we started a little bit late. I think we're gonna take a break now, just to give you guys a break to stand up a little bit, and then we'll come back and dive in, okay?
Oh, so hard.
That's what they call it.
Do you want me to pause this, Pales? How do you do that? You got this.
I went by, so I